The last few topics we'll discuss in biochemistry are fatty acid and cholesterol metabolism. Do you remember from the beginning of the metabolism section where fatty acid synthesis and degradation take place? Fatty acid synthesis takes place in the cytoplasm, whereas fatty acid breakdown occurs in the mitochondria. Let's start with fatty acid synthesis, or how fatty acids are made. As you can see, acetyl-CoA is a substrate or building block for fatty acid synthesis, but it's also used as the starting substrate to make cholesterol and ketone bodies, which we'll talk about in a bit. The first step in fatty acid synthesis is transporting the acetyl-CoA from the mitochondria to the cytosol using the citrate shuttle, which also creates NADPH. Why is the acetyl-CoA found in the mitochondrial matrix? Would it make more sense if it just started in the cytoplasm where fatty acids are made? Well, remember a molecule of pyruvate is turned into acetyl-CoA from the pyruvate dehydrogenase complex, which is located in the mitochondrial matrix. To think of this a different way, the acetyl-CoA then must find a bus station in the mitochondria. Hop on the citrate shuttle and get off at the cytosol shuttle stop, where the fatty acid synthesis can finally occur. We'll see fatty acid metabolism take place in three primary locations. It mostly occurs in the liver, adipose tissue, and also lactating mammary glands. Once in the cell cytoplasm, the 2-carbon acetyl-CoA is carboxylated to the 3-carbon malonyl-CoA, which requires the enzyme acetyl-CoA carboxylase. Like most carboxylation reactions, the vitamin biotin is used as a cofactor. This step is the rate-limiting step of fatty acid synthesis and therefore is the most heavily regulated. Next, the enzyme fatty acid synthase is used to add 2 carbon units from malonyl-CoA to the growing fatty acid chain until it reaches its full length. This also requires NADPH, which was conveniently produced using the citrate shuttle. Subsequent modification of palmitate can lead to further chain elongation, desaturation, or acylglycerol formation. Now that we've built up a nice fatty acid molecule, let's tear it down. Fatty acid degradation, also known as beta oxidation, occurs in the mitochondria, since this is where its breakdown products will be used. A long fatty acid chain and CoA get converted into 2 carbon units of acetyl-CoA by the enzyme fatty acid-CoA synthetase. These acyl-CoA molecules are transported into the mitochondria using the carnitine shuttle, which is inhibited by a buildup of malonyl-CoA, a substrate that we just used to synthesize fatty acids. Why would malonyl-CoA inhibit the carnitine shuttle? So you don't break down fatty acids when you're trying to make them. Once we've successfully moved our fatty acyl-CoA to the mitochondria via the carnitine shuttle, we encounter the enzyme acyl-CoA dehydrogenase, which makes a double bond in acyl-CoA which is required for beta oxidation. This results in acetyl-CoA molecules, which can then enter the TCA cycle or be used more directly for energy, for example, to make ketone bodies. If all else fails, on test day, remember that the citrate shuttle is involved in fatty acid synthesis, and the carnitine shuttle is involved in fatty acid carnage. When everything works correctly, our fatty acyl-CoA uses the carnitine shuttle to enter the mitochondria. However, what would happen if the carnitine shuttle wasn't working correctly? In patients with systemic primary carnitine deficiency, there's an inherited defect in the carnitine shuttle, which prevents the long-chain fatty acids from entering the mitochondria. These patients will usually present with generalized weakness, hypotonia, and hypoketotic hypoglycemia. And why would it be hypoketotic? Well, during times of hypoglycemia, our body usually turns to fat reserves for energy. If we don't have our carnitine shuttle working, we get a toxic buildup of fatty acyl-CoA that's stuck in the cytoplasm. This fatty acyl-CoA can't get converted to ketone bodies or enter the TCA cycle in these patients. So, in patients with systemic primary carnitine deficiency, you'll see hypoketotic hypoglycemia. What do you suspect an acyl-CoA dehydrogenase deficiency will cause? If you don't have the acyl-CoA dehydrogenase enzyme, beta oxidation can't occur, so fatty acids can't be converted into acetyl-CoA. Without acetyl-CoA, glucose and ketones can't be formed, and this ultimately results in an increase in dicarboxylic acids. Medium-chain acyl-CoA dehydrogenase deficiency is an autosomal recessive disorder which leads to the buildup of 8 to 10 carbon fatty acyls in the blood. Again, the clinical presentation will be a younger patient who may have hypoketotic hypoglycemia, the same as we saw earlier. This patient may have lethargy, seizures, vomiting, or liver dysfunction. How will we treat a patient with medium-chain acyl-CoA dehydrogenase deficiency? Well, let's think about it. When do we use beta oxidation? We use beta oxidation to break down fats when our glucose levels are depleted. So treatment is to keep our body supplied with a constant source of glucose and avoid fasting. From our discussion on fatty acid metabolism, we talked about how fatty acids can be converted into acetyl-CoA, which then enters the TCA cycle. However, they can also be turned into ketone bodies. The ketogenesis pathway is shown here. I'm not going to spend much time on this pathway since it isn't super high yield for the boards. However, I'll touch upon what you need to know. What are the three ketone bodies? The ketone bodies include acetoacetate, beta-hydroxybutyrate, and acetone. So why do our cells make ketone bodies? Well, when the amount of glucose available isn't sufficient for the energy needs of the brain, so in other words a prolonged hypoglycemic state, free fatty acids will be used for energy. The liver can convert free fatty acids and ketogenic amino acids into ketone bodies, primarily acetoacetic acid and beta-hydroxybutyrate, which can then be metabolized by the brain and muscle into 2 molecules of acetyl-CoA for energy. Since ketones can only be used in the mitochondria of a cell, they can't be used in erythrocytes, since mature RBCs have no mitochondria. In prolonged starvation and diabetic ketoacidosis, oxaloacetate must be used for gluconeogenesis, and therefore it becomes depleted from the TCA cycle. Also, in alcoholism, excess NADH converts oxaloacetate into malate, which we discussed earlier. These both cause a buildup of acetyl-CoA, which now gets converted into ketone bodies. Why are ketone bodies important clinically? Well, the acetone that's made can give one's breath a fruity odor, which can indicate to you that someone is in diabetic ketoacidosis. There's a urine test for ketones, but it does not detect beta-hydroxybutyrate. One final point is that the liver makes most of the ketone bodies, but it lacks the enzymes needed to use them. Okay, flash quiz time. Let's do a clinical example using ketone bodies. An 18-year-old with type 1 diabetes stops taking his insulin and eventually develops fruity-smelling breath and ketones in his urine. Why? This man developed ketoacidosis because he depleted oxaloacetate, since his body ramped up gluconeogenesis. Since he depleted his oxaloacetate, his TCA cycle stalled, which shunts glucose and free fatty acids into ketone production to supply fuel for his brain and heart.